Let's cut through the noise and get straight to the heart of a clinical challenge we all face. The late stages of peripheral artery disease. You know these patients well. Those dealing with devastating non-healing wounds and relentless rest pain. It's complex, often debilitating, and frankly demands our sharpest focus.
Absolutely. This isn't just another vascular issue. It's chronic limb-threatening ischemia, a condition that places patients at, well, very high risk for major amputation, severe pain, and significantly impacts the quality of life and even survival.
Exactly. And recognizing the evolving nature of this disease and our management capabilities. 3 major global vascular societies, the European Society for Vascular Surgery, the Society for Vascular Surgery, and the World Federation of Vascular Societies, they came together. They convened a writing group of 58 experts from 24 countries to create a comprehensive set of global vascular guidelines.
It's a monumental effort, really, to synthesize the available evidence and expert consensus on managing chronic limb-threatening ischemia. A huge undertaking.
And that's our mission today, to dive deep into these global vascular guidelines. We're going to unpack the fundamental shifts in definition, the essential assessment tools, the nuanced management strategies, the underlying evidence base, and even touch on the controversies and the open questions this global group identified. This deep dive is specifically tailored for you, the specialist clinician, grappling with these challenging cases every day.
So where should we start? The definition seems key.
Let's start right there at the beginning by understanding how these guidelines redefine the landscape.
Okay. One of the first things these guidelines do is, well, redefine the condition itself. The term critical limb ischemia, or CLI, has been used for years, but these guidelines now consider it outdated.
Okay, so we're moving away from critical limb ischemia to chronic limb-threatening ischemia. Why the change? What's the thinking there?
The term chronic limb-threatening ischemia, or CLTI, is preferred because it better encompasses the broader, more heterogeneous patient population we actually see in practice.
Heterogeneous how?
It acknowledges that limb threat exists on a spectrum. You often see it presenting with tissue loss or infection, even in patients who might not meet those traditional, sometimes rigid, hemodynamic cutoffs previously associated with CLI. So CLTI is a more inclusive and arguably a more clinically relevant definition for day-to-day work.
That makes sense, recognizing the complexity and variability of the presentation. So what are the overarching goals laid out in this guideline document?
The primary goal is quite ambitious: to improve the quality of care for all patients with chronic limb-threatening ischemia, and importantly also for those who are at risk of developing it.
Okay.
And a significant secondary goal is to clearly identify key research priorities across the spectrum, from basic science to health services, really to advance our understanding and treatment.
Identify what we know, standardize care based on that, and point the way forward for what we don't know yet.
Precisely.
Speaking of standards, one thing that really jumped out from the source material was the guidelines' strong commitment to transparency and managing conflicts of interest.
Yes, that's a notable feature. The societies involved were very clear about the need for trustworthy clinical practice guidelines, emphasizing transparency and full disclosure from everyone involved, from the writing group to the steering committee.
And they put some pretty strict rules in place, right?
Yeah.
Not just disclosure, but actual limitations.
Exactly. The intent was really to ensure industry had absolutely no direct influence on the clinical content or the recommendations themselves.
How did they manage that?
They required everyone involved, co-editors, authors, everyone, to disclose their relationships with industry before the work even began, specifically to assess eligibility. And this continued throughout the entire process. Full transparency.
And a financial cap for the co-editors was quite low, wasn't it?
It was. The co-editors were required to have less than $10,000 in industry income in aggregate during their work on the guidelines. That's a stringent requirement, and it reflects the commitment to impartiality at the leadership level. They also mandated that more than 50% of the steering committee members meet similar criteria regarding their industry relationships.
And importantly, no direct industry funding for the guideline development itself.
That's correct. Direct industry funding for this specific initiative was explicitly not accepted by the participating societies, and industry involvement in the actual writing or review process was strictly prohibited. It's a level of detail and commitment to independence that really stands out.
A strong foundation of transparency, then. Let's move into the clinical assessment side. Once we suspect chronic limb-threatening ischemia, how do these guidelines recommend we confirm and quantify it?
The guidelines are unequivocal here. Objective hemodynamic testing is essential. Recommendation 1.1 gives us a Class 1 strong recommendation.
Class 1 strong.
although the level of evidence is C low.
Okay, what does that mean, level C low?
It means that while large-scale randomized trials might be limited, the expert consensus based on clinical experience and other available data is very strong. The bottom line is, you must objectively measure the presence and severity of ischemia. No guesswork.
What are the first-line non-invasive tests we should be reaching for then?
The primary non-invasive tests recommended are ankle pressure and the ankle brachial index, or ABI. This is recommendation 3.4, another class 1 strong recommendation, this time with a level of evidence B moderate.
Okay, standard practice, but there's a critical pitfall with ankle pressure and ABI, especially in certain patients, isn't there? I think we've all seen this.
There absolutely is, and it's crucial for CLTI patients. Ankle pressure and ABI can be falsely elevated due to medial calcinosis, that's calcification in the arterial wall, which makes the vessels non-compressible.
Right, the stiff arteries.
Exactly, and this is particularly common in patients with diabetes mellitus and those with end-stage renal disease. So relying solely on a normal or even a high ABI in these patients can be dangerously misleading.
So how do we get an accurate picture of perfusion in those high-risk groups? What's the workaround?
In patients with suspected chronic limb-threatening ischemia, especially those with tissue loss, the guidelines strongly recommend measuring toe pressure and the toe brachial index, or TBI.
Okay, toe pressure.
This is recommendation 3.5, class 1 strong recommendation, backed by a level of evidence A high. That's top-level evidence.
Level A high, okay.
And the source material highlights that in patients with diabetes or end-stage renal disease, toe pressure and transcutaneous oximetry measurements, known as TCPO2, are actually preferred.
And why are toe pressure and TCPO2 better indicators in these specific patients?
Because they are much less affected by that medial calcinosis. The digital arteries usually aren't calcified like the tibial arteries, and studies show they are more accurate and more predictive of adverse outcomes.
Predictive of what specifically?
The guideline specifically cites data demonstrating that a toe pressure less than 30 millimeters of mercury or a TCPO2 less than 10 millimeters of mercury are predictive of major amputation at 1 year.
That's a stark number.
It is. The source even mentions one study where using only ankle pressure failed to identify 42% of patients who actually had CLTI based on toe pressure criteria.
Wow, almost half.
Missing almost half the patients based on ankle pressure alone is a powerful argument for using toe pressure or TCPO2 routinely in these populations.
That's really compelling. So objective testing is non-negotiable, and we need to be smart about which test we prioritize based on patient characteristics, especially using toe pressure or TCPO2 in those with diabetes, end-stage renal disease, or tissue loss.
Exactly.
Let's define that tissue loss aspect more clearly. What exactly qualifies as tissue loss in this context according to the guidelines?
Tissue loss in chronic limb-threatening ischemia is defined as gangrene affecting any part of the foot or a non-healing ulceration that has been present for at least 2 weeks.
Okay, 2 weeks minimum.
Critically, this must be accompanied by objective evidence of significant peripheral artery disease. The example given is a wound, ischemia, and foot infection ischemia grade of class 1 or higher using the WIFI classification system.
Ah, the WIFI system. Okay, tell us about that. How does the guideline recommend we use it?
The Society for Vascular Surgery's Wound, Ischemia, and Foot Infection Classification System, WIFI, is strongly recommended for use in all patients with suspected CLTI. This is recommendation 1.2, a class 1 strong recommendation, again with a level of evidence C low.
So, strong recommendation, but based more on consensus and utility than large trials.
Right. Its clinical value is widely accepted.
What are the components of WIFI, and what does it help us achieve clinically?
WIFI systematically assesses the severity of the wound, the degree of ischemia, and the presence and severity of foot infection. Each of these 3 components, wound, ischemia, infection, is graded on a scale from 0 to 3.
0 to 3 for each.
Wound grades 0 to 3, ischemia grades 0 to 3, and infection grades 0 to 3. By grading each, you arrive at an overall WIFI stage, typically stage 1 to 4.
And how does this staging inform our decisions? What does it predict?
Staging the limb threat using WIFI correlates with important clinical outcomes. It helps predict the probability of successful limb salvage, the patient's risk of major amputation, and the likelihood of wound healing.
So it standardizes things.
Exactly. It standardizes how we describe the severity of the limb threat, moving beyond subjective terms like minor or major tissue loss. The source also points out that WIFI staging can help predict which patients might derive greater benefit from open surgical bypass versus endovascular therapy.
How so?
Well, it references studies that showed worse outcomes for endovascular therapy in patients classified as WIFI stage class 4, the most severe category.
That's a critical link between assessment and potential treatment choice.
Mm.
So objective hemodynamics, especially toe pressure TCPO2 plus WIFI staging. Now, if a patient is a candidate for revascularization, what kind of imaging is required for planning?
For patients being considered for revascularization, comprehensive imaging is absolutely required. The guidelines mention this in Section 6, which covers the revascularization strategies.
And what's the goal of that imaging?
The imaging needs to allow for complete anatomic staging. It needs to detail the extent and nature of the arterial disease from the aorta down to the foot. This often involves using a system like the Global Limb Anatomic Staging System, or GLAS, which we should probably talk about too.
We will. But first, let's break down the imaging modalities discussed. Computed tomography angiography, CTA, magnetic resonance angiography, MRA, and the traditional digital subtraction angiography, DSA. What are their respective strengths and weaknesses according to the guidelines?
Okay. Digital subtraction angiography, or DSA, is still considered the gold standard by many vascular specialists,
Why is that?
primarily because it provides the best spatial resolution, the finest detail, and allows for real-time visualization during an intervention if you proceed directly from diagnosis to treatment.
Right, the on-the-table view. How does computed tomography angiography stack up?
Computed tomography angiography, CTA, is very good at precisely quantifying calcification, which can be really helpful for surgical planning, especially for endarterectomy or deciding clamp sites.
But it has downsides.
It does. It uses potentially nephrotoxic iodinated contrast, which is a big concern in many CLTI patients who often have kidney disease. It involves radiation exposure, and it can be less reliable for accurately visualizing the smaller, complex infrapopliteal vessels, especially in the presence of heavy calcification, which can cause artifacts. The source also notes that studies evaluating CTA haven't always included representative numbers of CLTI patients, particularly those needing detailed foot imaging.
Okay. And magnetic resonance angiography, MRA, what are the pros and cons there?
Magnetic resonance angiography, or MRA, is attractive because it's non-invasive, uses no ionizing radiation, and importantly, its image quality is unaffected by arterial calcification. That's a significant advantage over CTA in heavily calcified legs. It also provides excellent three-dimensional images.
Sounds good, but what are the limitations?
Well, older MRA techniques could sometimes overestimate stenosis severity, and because it doesn't visualize calcification, you might underestimate the technical difficulty of a subsequent endovascular intervention you don't see the rock you need to get through.
Slow flow, common in CLTI, can cause issues like venous overlay, particularly in the distal foot, making interpretation tricky. Plus, availability and cost can be barriers, and interpretation often requires a subspecialist radiologist.
Are there specific MRA techniques preferred now?
Yes. The guideline notes that newer techniques, especially non-contrast enhanced MRA, are emerging as excellent options for distal vessel assessment in CLTI, avoiding contrast issues altogether. But contrast-enhanced MRA using gadolinium-based contrast is still generally preferred for a comprehensive assessment.
How good is it for the foot vessels?
For the foot specifically, contrast-enhanced MRA has demonstrated a sensitivity of around 92% for detecting significant disease in specialized centers, which is quite good. But slow flow remains a limitation even with contrast.
What about duplex ultrasound for imaging? We rely on that heavily for surveillance, but what about for initial planning? Duplex ultrasound, DUS, is definitely mentioned. It's invaluable, as you say, for surveillance and assessing hemodynamics. But the guideline points out that for initial anatomic planning in complex CLTI, it's often less accurate for visualizing the very distal vessels and the intricate anatomy within the foot compared to angiography.
So good for inflow, maybe fempop, but less reliable for the really detailed below-the-knee planning.
Generally, yes. While it's essential for hemodynamic assessment and surveillance, its detail diminishes for planning complex infrapopliteal and pedal revascularizations compared to DSA, CTA, or MRA.
Okay, so to recap the assessment part, we need objective hemodynamics tailored to the patient, favoring toe pressure or TCPO2 in diabetics, renal patients, or those with tissue loss. We need standardized limb threat assessment using WIFI wound ischemia infection. And for revascularization candidates, detailed anatomic imaging like DSA, CTA, or MRA, understanding the pros and cons of each.
That really covers the diagnostic groundwork laid out in the guidelines, a systematic approach.
Absolutely. Now let's shift our focus a bit to the patient as a whole, their risk factors, their overall prognosis. What insights do the guidelines offer on the epidemiology of chronic limb-threatening ischemia? How common is this?
Well, a key point the guideline makes up front is the surprising lack of reliable global data on CLTI epidemiology, particularly from low and middle income countries.
Really? Why is it so hard to track?
They caution that estimates extrapolated from, say, intermittent claudication data or even amputation statistics can be highly misleading. CLTI is distinct. And unfortunately, patients with severe CLTI often have high mortality rates, meaning they might die before being captured in typical prevalence studies focused on survivors.
That makes sense. So precise numbers are hard to come by globally. But are there any demographic trends that emerge from the available data or this specialist survey mentioned in the source?
The available data and the survey responses do suggest some interesting and sometimes concerning trends. Historically, peripheral artery disease prevalence has been reported as higher in men in high-income countries. However, in low- and middle-income countries, the data suggests it might actually be higher in women.
That's interesting.
And a particularly concerning trend highlighted is a rise in the overall burden of PAD in women, and significantly in younger age groups. This is especially noted in low- and middle-income countries. Table 13.2 in the source specifically details this worrying increase in younger, often economically productive populations.
That has significant implications beyond just healthcare, societal, and economic impacts, too. What about the well-established risk factors for CLTI? What do the guidelines reiterate?
The guidelines cover critical risk factors in Recommendation 4.1. This gets a Class 1 strong recommendation, level of evidence B moderate. The key modifiable risk factors are, unsurprisingly, smoking, diabetes mellitus, hypertension, and dyslipidemia.
Any specific nuances mentioned regarding dyslipidemia?
Yes, elevated total cholesterol and low-density lipoprotein cholesterol LDLC are clearly identified risk factors. The source also notes that low high-density lipoprotein cholesterol levels, low HDLC, appear associated with increased mortality in PAD patients.
And triglycerides.
The precise role of hypertriglyceridemia in PA development and progression remains less clear or perhaps incompletely defined according to the guideline. Focus remains primarily on LDLC.
And chronic kidney disease, you mentioned that earlier regarding testing.
Chronic kidney disease, CKD, especially end-stage renal disease, ESRD, is strongly emphasized. It's a powerful risk factor for developing CLTI and a significant predictor of poor outcomes. Worse wound healing, higher amputation rates, higher mortality.
Are there other, perhaps less traditional factors mentioned that clinicians should be aware of?
Yes, the guideline does list others. Things like air pollution, chronic inflammation marked by elevated C-reactive protein, and homocysteine, although the benefit of treating homocysteine with folate is noted as uncertain.
What about non-biological factors?
Family history and genetics are discussed, but their overall significance in predicting CLTI is still considered uncertain. Lower socioeconomic status and lower educational attainment are clearly associated, often intertwined with other risk factors like smoking or poor diet. And there's also mention of increasing evidence that chronic mental and psychosocial stress might have direct adverse cardiovascular effects contributing to PECLTI.
It's a really complex interplay of factors, isn't it? Biological, social, environmental.
It really is.
Given all this, what's the overall prognosis for someone diagnosed with CLTI? How serious is it?
Chronic limb-threatening ischemia is associated with markedly increased cardiovascular morbidity and mortality. It's a marker of severe systemic atherosclerosis. This is especially pronounced in low- and middle-income countries.
On the limb itself.
The guideline states that if left untreated, the overall risk of major limb loss is around 25% at 1 year. But, and this is crucial, that risk is significantly higher for patients who present with extensive tissue loss, like those WIFI stage 3 or 4 patients. For them, the risk can be much higher.
So it's not just a local limb issue. It's a systemic disease with high risk of heart attack, stroke, and death, in addition to a high risk of limb loss.
Exactly. It signals danger for the patient systemically.
Given that grim prognosis, if untreated, what's the cornerstone strategy for preventing limb loss according to these guidelines?
The guidelines are very clear on this. The key is aggressive risk factor management and what they term best medical therapy, combined with timely evidence-based revascularization, or EBR. These are seen as the essential pillars for preventing limb loss in CLTI. You need both.
Let's drill down on that best medical therapy. What are the specific medical management recommendations outlined?
Recommendation 4.2, a Class 1 strong recommendation, level of evidence B moderate, states that all modifiable risk factors should be managed to recommended levels in all patients with suspected chronic limb-threatening ischemia. It's foundational.
Okay, starting with antiplatelet therapy, what's the guidance there?
Yes, antiplatelet therapy is fundamental. Recommendation 4.3, a Class 1 strong recommendation, level of evidence, a high,
Yeah.
strongly recommends treating all CLTI patients with an antiplatelet agent.
Which agent?
This is typically aspirin, commonly dosed at 75 to 150 milligrams per day. Clopidogrel is presented as an acceptable alternative if aspirin isn't tolerated or contraindicated.
There's often a lot of discussion around dual antiplatelet therapy, DAPT, in this population, especially post-intervention. Does the guideline address initial therapy?
It does address the debate between DAPT and single antiplatelet therapy, or SAPT. It references trials like COMPASS, which looked at dual pathway inhibition, aspirin plus low-dose rivaroxaban, and showed lower major adverse cardiac events, MACs, and major adverse limb events, MALEs, but at the cost of increased bleeding. It also mentions the EDIDAPT trial, which specifically looked at DAPT versus SAPT in a PAD population and was negative for limb events. So while single antiplatelet therapy is a Class 1 recommendation for all patients initially, the role of DAPT is more nuanced and comes up again mainly in the context of post-intervention management, which we'll get to.
Okay. How about lipid management?
Statins are strongly recommended for all patients with chronic limb-threatening ischemia, no question. This is recommendation 4.4, Class 1 strong, level of evidence, a high.
Any particular intensity?
The source highlights the benefit of high-dose, high-intensity statins, citing a meta-analysis by Mills. The goal is aggressive LDL-C lowering. It also mentions ezetimibe and PCSK9 inhibitors, such as evolocumab, referencing the Fourier trial, as additional options for patients who need further LDL-C lowering beyond what statins can achieve.
And blood pressure control, what's the target?
Controlling blood pressure is important. The primary target recommended is less than 140 over 90 millimeters of mercury. This is recommendation 4.8, Class 1 strong, level of evidence a high.
Should we aim lower, like in some other cardiovascular guidelines?
The guideline notes the potential benefit of even lower targets, citing the SPRINT trial, which targeted systolic pressure below 120. But it points out that this intensive approach led to an increased risk of hypotension, falls, and possibly acute kidney injury in some populations.
Right.
So the primary recommendation remains below 14E90, with lower targets considered cautiously, balancing risks and benefits for the individual patient.
Does the choice of antihypertensive agent matter?
Interestingly, the guideline adds that the first-line category of oral antihypertensives, whether it's ACE inhibitors, calcium channel blockers, diuretics, doesn't appear to make a significant difference in cardiovascular event reduction as long as the target blood pressure is successfully reached.
Diabetes control is obviously crucial given the overlap with medial calcinosis, tissue loss, and infection risk.
Absolutely. Optimal glycemic control is very important. The guideline mentions a target like a hemoglobin A1C less than 7% as an example goal. This is recommendation 4.9, Class 1 strong, level of evidence B moderate.
How does it frame the evidence on intensive control?
It briefly touches on the big historical trials, DCC-TEDIC in type 1, UKPDS, ACCORD, ADVANCE, VADT in type 2, highlighting the complexity. While better glucose control reduces microvascular complications, the impact on macrovascular outcomes is less consistent across trials, and there's always the risk of hypoglycemia with very intensive control strategies. It's a balance.
There's been significant discussion recently about SGLT2 inhibitors and potential associations with foot complications, particularly amputations. Does the guideline weigh in?
It notes this as an area of ongoing discussion and scrutiny. It references the context of the CANVAS trial, which initially raised this concern, and subsequent meta-analyses regarding SGLT2 inhibitors and a potential link to foot ulcers or amputation risk. It doesn't make a specific recommendation, but indicates this is an evolving area the clinician needs to be aware of when choosing therapies.
Okay. Smoking cessation is perhaps the single most impactful thing a patient can do for their vascular health. What does the guideline emphasize here?
The recommendation for smoking cessation is extremely strong, unsurprisingly. Recommendation 4.12, Class 1 strong, level of evidence a high, states that comprehensive interventions, Pharmacotherapy, counseling, behavior modification should be offered to all patients with CLTI who smoke or use any form of tobacco.
And it stresses repeated intervention, right?
Yes. Recommendation 4.13, also Class 1 strong, level of evidence a high, specifically mandates asking about tobacco use status at every single patient visit. It underscores the continuous nature of this intervention. It's not a one-time conversation.
Checking tobacco status at every visit. That's a key behavioral change for us as clinicians, making it routine. Any other medical or lifestyle points covered? Diet, exercise.
Dietary recommendations are included. Recommendation 4.1, Class 1 strong, level of evidence a high, encourages low-fat or Mediterranean-style diets. It does acknowledge the practical challenges of implementing these, particularly in low- and middle-income countries where access and costs can be barriers.
And exercise, usually a big part of PAD management.
Exercise is mentioned, noting its clear benefits for intermittent claudication symptoms. However, the guideline acknowledges the limited data specifically in the CLTI population. Many of these patients simply cannot exercise due to rest pain, non-healing wounds, or general frailty, so its role is less established in active CLTI.
Makes sense. Pain management is critical for quality of life, especially with that awful ischemic rest pain.
Absolutely critical. Recommendation 4.14, Class 1 strong, level of evidence B moderate, states that appropriate analgesics should be prescribed for CLTI patients suffering from ischemic rest pain. And this should continue until the pain resolves following successful revascularization. You have to treat the pain while you're working on fixing the underlying problem.
Finally, there's a specific consideration regarding metformin use around procedures involving iodinated contrast. What's the advice?
Yes, this is relevant given the frequent need for angiography. Recommendation 4.11, which is a Class 2 week recommendation with a level of evidence C low, suggests considering withholding metformin immediately before and for 24 to 48 hours after administering an iodinated contrast agent in diabetic patients.
Why is that?
It's primarily a precaution against the rare but serious complication of lactic acidosis, should the patient develop contrast-induced nephropathy. The risk is considered higher if the patient's kidney function is already significantly impaired, specifically if the estimated glomerular filtration rate is less than 30 milliliters per minute per 1.73 meters squared.
So it's a weaker recommendation based on lower evidence, but an important point to consider, especially in patients with poor kidney function undergoing CTA or DSA.
Correct. A practical point for procedural planning.
Okay, so let's quickly recap that crucial medical management piece. It's aggressive management of all risk factors. Smoking, cessation, counseling, and checking status at every single visit. Optimal glycemic control aiming for A1C under 7% where feasible. Blood pressure below 1490, possibly lower with caution. Statins for absolutely everyone, usually high intensity. Antiplatelet therapy for everyone, typically aspirin first line. Appropriate pain relief until revascularization works. Considering metformin holds around contrast, especially with low eGFR, and encouraging healthier diets.
That's a really good summary. It's a comprehensive package essential for improving both limb and patient survival.
Right, that sets the stage with medical therapy. Now, for many patients, the definitive step for limb salvage is revascularization. The guideline states that effective revascularization is the cornerstone of limb salvage in chronic limb-threatening ischemia.
It is indeed. The primary goal of revascularization in CLTI is fundamentally to achieve durable relief of rest pain and, critically, to heal tissue loss by restoring sufficient blood flow to the affected foot.
And the guidelines propose a specific framework to help clinicians navigate the often complex decision on the optimal revascularization strategy, the plan approach. Can you walk us through that?
Yes, the plan approach is an integrated, three-step decision-making framework. It's designed to help standardize and guide the choice between the two main revascularization options: open surgical bypass and endovascular intervention. PLAN stands for patient risk, limb severity, and anatomic complexity.
Okay, let's break those down. First, patient risk. What goes into that?
Patient risk involves evaluating the individual patient's estimated procedural risk. How likely are they to have complications from the intervention itself? And also their estimated longer-term, say, 2-year all-cause mortality risk, reflecting their overall health and comorbidities.
How does that help guide the choice?
It helps categorize patients, for instance, as average risk or high risk for open surgery. A patient deemed high surgical risk might be steered more towards a less invasive endovascular approach, even if the anatomy is complex.
Okay. Next is limb severity. That sounds like it ties back to the WIFI system we discussed earlier.
It does, directly. Limb severity utilizes the WIFI classification system, grading the wound, ischemia, and foot infection components from 0 to 3 each, leading to an overall stage. This provides that standardized measure of the magnitude of the limb threat, which influences treatment urgency and the potential benefit expected from revascularization. A more threatened limb might warrant a more durable procedure if possible.
And the final piece, AN for anatomic complexity, uses the new Global Limb Anatomic Staging System, or GLAS.
Precisely. The Global Limb Anatomic Staging System, or GLAS, is addressed in Recommendation 5.1 as a good practice statement. It's a critical tool here. It's designed to define the complexity of the preferred target artery path, or tap the intended route for revascularization from the inflow vessel down to the foot.
And what does knowing the complexity of the TAP tell us?
GLASs helps estimate the likely limb-based patency, or LBP, of that chosen revascularization route. Essentially, it helps predict how technically challenging the intervention might be, and importantly, how likely that specific repair or bypass is to stay open over time, based on the location and severity of the lesions involved.
So GLAS provides a standardized way to discuss anatomic challenges and help stage the complexity of the planned intervention into 3 stages. Stage 1, 2, 3.
Yes, it stages the complexity for intervention into 3 stages based on the TAP. This facilitates evidence-based revascularization by linking the specific anatomy to predicted outcomes like patency, allowing for more informed choices.
How does the availability of a good quality autogenous vein factor into this planned framework? That seems like a big variable for open surgery.
It's highlighted as a key factor, absolutely. In certain scenarios, particularly for complex anatomy, like high JOS stages, where long-term durability is paramount, the generally superior long-term patency of vein grafts compared to prosthetic conduits or many endovascular interventions makes vein availability a significant consideration. If a good vein is available, it might tilt the balance towards bypass surgery for eligible patients.
Okay, so we evaluate patient risk, limb severity using WIFI, anatomic complexity using GLAS, and we factor in vein availability. How do these factors combine to inform the general recommendations for choosing between endovascular and open strategies? What's the overall picture?
The introductory section of Section 6 on revascularization synthesizes this quite nicely. Generally speaking, based on the current evidence, for average risk patients who have advanced limb threat, that's WIFI stages Class 3 and Class 4, and high anatomic complexity disease, GLAS stage Class 3, then vein bypass may be preferred, assuming good vein is available.
Okay, so average risk, bad limb, complex anatomy, good vein, leans towards bypass.
That's the idea. Conversely, patients who have less complex anatomy, say GLAS stage Class IA or Class 2, perhaps intermediate severity limb threat, WIFI stage Class 2, or crucially, those who are high surgical risk patients. These individuals may be favored for an endovascular intervention first.
So higher patient risk pushes towards endo, as does simpler anatomy or less severe limb threat.
That's the synthesis based on current data. But it's really important to note, as the guideline writers do repeatedly, that these recommendations are based on the best available data, which has limitations. They are explicitly pending the availability of level 1 evidence from ongoing, large randomized controlled trials like BEST-CLI and BASIL-2, which are directly comparing these strategies head-to-head in contemporary practice.
Right, waiting on those big trial results. What about patients who seem to have no option anatomy based on imaging? We see reports saying no distal targets. Is that always the final word?
The guideline is careful here. It states that the definition of no option anatomy is very much clinical context dependent. It depends on the patient's symptoms and limb threat severity.
How so?
For a patient with only ischemic rest pain or perhaps minor tissue loss, say WIFI stage Class 2, sometimes just fixing inflow disease or treating a femoropopliteal segment, even without reestablishing continuous straight-line runoff to the foot, might provide enough improvement in perfusion to relieve pain or heal a small ulcer.
So no option for a full bypass might not mean no option for any beneficial intervention in milder cases.
Exactly, but for more severe tissue loss.
For advanced CLTI patients with significant tissue loss, those WIFI stages Class 3 and Class 4, the lack of an identifiable arterial target that crosses the ankle joint, or the absence of a suitable pedal or plantar artery target, which is categorized under the GLAS P2 modifier, indicating poor pedal outflow, may constitute a pattern of anatomically no-option disease based on imaging.
May constitute, not definitively.
Well, the guideline also notes that surgical exploration, actually opening the leg or foot in the operating room, can sometimes reveal a usable, albeit small or diseased, arterial target that wasn't clearly visible on preoperative angiography. So there might still be a chance even in seemingly no-option cases based on imaging alone. That's a crucial point. Don't necessarily give up based on imaging alone in those severe tissue loss cases, especially if surgery is feasible. Explore.
It emphasizes the potential value of exploration in select cases.
What is the overall evidence base that these revascularization recommendations are built upon? You mentioned limitations.
The guideline reviews the evidence base quite critically, acknowledging its limitations. The bypass versus angioplasty in severe ischemia of the leg trial, Basel 1, conducted years ago in the UK, is highlighted as the only large, multi-center randomized controlled trial published to date that directly compared an endovascular first versus a bypass first strategy specifically for limb-threatening ischemia.
Just one major RCT. What are the key limitations of the existing evidence landscape overall for CLTI revascularization?
There are several key limitations. Many peripheral intervention studies, especially older ones, included relatively few CLTI patients compared to those with milder claudication, so results might not fully apply. Most femoropopliteal bypass studies, particularly below the knee, involve prosthetic grafts, which we know have less favorable long-term patency compared to vein.
Okay.
And importantly, many endovascular studies looking at infrapopliteal disease often included patients with less complex anatomy, like GLAS infrapopliteal grades Class 1 and Class 2. There's a distinct lack of robust data on treating the highly complex multi-level disease patterns commonly seen in advanced CLTI, particularly that GLAS IP grade Class 4 disease. The evidence is really weakest for the most challenging distal anatomies we face.
So the evidence base is weakest precisely where the clinical challenge is greatest. That's problematic.
It is a major challenge highlighted by the guideline.
Despite these limitations, what's the current synthesis of the data comparing endovascular and bypass surgery outcomes, broadly speaking?
The synthesis presented is that at 1 year, the available data suggests generally similar mortality rates, similar major amputation rates, and therefore similar amputation-free survival rates between endovascular first and bypass first strategies.
Similar early limb salvage and survival. But what about patency? How long do the repairs last?
That's where a difference emerges. The data consistently shows improved patency rates for bypass surgery using an autogenous vein conduit compared with either endovascular interventions or bypasses using prosthetic grafts. And this patency advantage for vein bypass often extends beyond 1 year, sometimes significantly so.
So similar early limb salvage, but vein bypass seems to offer better durability, which might translate to fewer reinterventions and better long-term outcomes, though more data is needed.
That's the current understanding, yes. Durability is the main advantage cited for vein bypass in appropriate candidates.
Let's look at specific anatomic approaches discussed in the guidelines. First, aortoiliac disease contributing to CLTI. What's the recommended approach there?
For aortoiliac disease causing or contributing to CLTI, an endovascular first approach is generally recommended for moderate to severe disease, specifically G-BLAST stage class IA, taking into account any prior interventions the patient may have had. This is recommendation 6.25, a class 1 strong recommendation, level of evidence B moderate.
And for more extensive iliac disease.
For extensive aortoiliac disease, defined as Dreyfus stage class 2, or importantly, after a failed endovascular intervention in the iliac segment, then surgical reconstruction, like an aortobicameral bypass, is considered the preferred option. This is recommendation 6.26, a class 2 weak recommendation, level of evidence B moderate.
Common femoral artery disease. That junction is often diseased.
Yes, the common femoral artery, CFA, endarterectomy surgically cleaning out the plaque is discussed. The guideline notes it can be performed with low morbidity and offers excellent long-term durability. This is presented as recommendation 6.27, a good practice statement reflecting strong consensus on its effectiveness.
Okay, moving down the leg to infranguinal disease, below the inguinal ligament. This is the bulk of CLTI interventions, right?
It is. For infranguinal disease in average-risk CLTI patients, the guideline states that the choice between endovascular intervention and open surgical bypass should be based on that integrated assessment we discussed: the severity of the limb threat, WIFI stage, the anatomic pattern of disease, GLAS stage and TAP-P, and the availability of suitable autologous vein. This is recommendation 6.32, class 1 strong, level of evidence C low. It emphasizes shared decision-making based on these factors.
And for high-risk patients with advanced limb threat, what if they have really bad wounds or gangrene but are too sick for a big operation?
For high-risk patients who have advanced limb threat, WIFI stage class 4, and significant perfusion deficits, WIFI ischemia grades class 2 and class 3, endovascular revascularization is recommended when technically feasible. This is recommendation 6.33, a class 1 strong recommendation backed by a level of evidence A high.
So in that specific scenario, sick patient, bad limb endo is preferred if possible.
It seems so. The rationale is likely minimizing the systemic stress of surgery in these very frail patients, prioritizing getting some flow improvement quickly and safely via endovascular means if a target can be treated that way.
What about the really challenging below-knee and pedal vessels? This is often where the rubber meets the road clinically, isn't it? Dealing with tibial and foot artery disease.
This is indeed the most challenging area anatomically in many CLTI patients. The guideline discusses the angiosome concept, the idea that you should ideally revascularize the specific artery that directly supplies the area of tissue loss.
Does the evidence support that targeted approach?
It's debated. The guideline notes that systematic reviews comparing angiosome-targeted revascularization versus indirect revascularization, just improving flow down any open vessel, have yielded conflicting results.
Why the conflict?
The outcomes seem to be heavily confounded by other factors, like the quality of the pedal arch circulation, whether the foot arteries connect well, and the specific type of revascularization performed, endo versus bypass. So while intuitively appealing, the clinical superiority of a strict angiosome-based strategy is not definitively proven across the board. The evidence remains less clear.
Are technical advancements in endovascular techniques for these tricky distal vessels changing the game? Things like new wires, catheters, pedal access.
The guideline briefly mentions these advancements: specialized wires, low-profile catheters, retrograde access techniques from the foot upwards, the pedal loop technique for crossing occlusions. These are all designed to help us tackle these complex distal lesions that were previously untreatable percutaneously.
But is it making endo the dominant strategy down there?
Not necessarily. The guideline explicitly states that despite these technical improvements, hemodynamic durability remains a primary limitation of endovascular interventions, particularly when dealing with high-complexity target path anatomy, like long occlusions, heavy calcium in the lower leg and foot. Getting flow there with a wire and balloon is one thing. Keeping it open long-term is quite another.
So patency is still the Achilles heel of endo in complex tibial disease.
It remains a major challenge compared to vein bypass, yes.
For open and franguinal bypass, then, what are the preferred approaches and conduits according to the guidelines?
The guideline details several key points for successful bypass. First, an acceptable target artery for the bypass must provide adequate runoff to the lower limb and foot to achieve clinical success healing the wound, relieving pain. This is recommendation 6.39, class 1 strong, level of evidence a high. You need flow out of the bypass.
Okay.
Second, this target artery should also be clearly accessible by imaging beforehand, which is recommendation 6.40, a good practice statement. You need to know where you're aiming.
And the conduit. What should the bypass be made of?
Most importantly, the guideline strongly recommends that infranguinal bypass should preferably be performed using an autogenous vein conduit, the patient's own saphenous vein ideally. This is recommendation 6.41, a class 1 strong recommendation, level of evidence a high. It reinforces the superior value of using the patient's own vein for better long-term patency compared to prosthetic materials or other conduits, especially for bypasses going below the knee.
So vein is king for bypass durability.
When available and of good quality, yes.
Okay, let's try to summarize this complex revascularization section. It emphasizes a strategic, individualized approach guided by the plan framework, carefully considering patient risk, limb severity using WIFI, anatomic complexity using GWASs, and crucially, vein availability. While endovascular and open approaches may yield similar early limb salvage rates, vein bypass generally offers better long-term patency, making it potentially preferred for complex anatomy and suitable surgical candidates with good vein. Endovascular might be favored for higher-risk patients or less complex anatomy. There are specific recommendations for different arterial segments, acknowledging the particular challenges and evolving techniques for distal tibial and pedal vessels, where endovascular durability remains a concern.
That's a very accurate overview of the key principles outlined in that section. It's about tailoring the strategy.
Okay, so that covers the revascularization strategies for patients who are candidates. But as we know, not all patients are candidates for intervention, or sometimes revascularization efforts just aren't successful or durable. What non-revascularization treatments does the guideline review for these challenging scenarios?
Right. The guideline dedicates a section to non-revascularization treatments, recognizing the clinical reality that a significant subset of CLTI patients either aren't anatomically suitable for revascularization, are too frail, or perhaps have had failed attempts. While major amputation is always an endpoint option in truly unsalvageable cases, these are alternatives discussed for palliation or potential limb preservation when revascularization isn't on the table.
Which specific non-revascularization options are covered in this section?
The guideline reviews several: spinal cord stimulation, SCS, lumbar sympathectomy, LS, intermittent pneumatic compression, IPC, prostanoids like prostaglandin E1, the drug psilostazole, hyperbaric oxygen therapy, HBOT, and it also touches on investigational biologic and regenerative medicine approaches.
Okay, let's take them one by one. Spinal cord stimulation, SCS. What's the proposed mechanism and the evidence base for its use in CLTI?
Spinal cord stimulation involves implanting electrodes near the spinal cord. It's thought to potentially help in CLTI by improving microcirculation, possibly through vasodilation, and by inhibiting sympathetic nerve activity, which might reduce pain and improve blood flow. The guideline references a 2013 Cochrane review of 6 controlled studies in patients who had inoperable CLTI.
And what did that Cochrane review find regarding SCS? Did it help?
The review suggested that SCS offered a modest positive effect on pain relief compared to conservative management, and importantly, it was associated with about an 11% reduction in the major amputation rate at 1 year in these no-option patients.
An 11% reduction sounds potentially significant. Any downsides?
Yes, it's important to be aware of the potential complications reported in those studies. The overall complication rate was around 17%, including things like problems with implantation, lead migration needing revisions, or infection at the device site.
So, potential benefit in reducing amputation and pain, but balanced against a not insignificant complication risk. What's the final guideline recommendation for SCS?
Recommendation 7.1 suggests considering spinal cord stimulation. The specific wording is, consider SCS to reduce amputation risk and decrease pain in carefully selected patients, typically those with primarily rest pain or maybe minor tissue loss where revascularization is not possible. This is a Class 2 weak recommendation with a level of evidence C low.
Weak recommendation, low evidence. So it's a conditional option, not a standard therapy.
Exactly. It highlights that it's an option to think about in a very specific subgroup based on limited evidence quality and requires careful patient selection and discussion of risks.
How about lumbar sympathectomy, LS? That's an older procedure. Surgically or chemically ablating the lumbar sympathetic chain. Is it still relevant?
Lumbar sympathectomy is also reviewed, but the guideline notes the supporting data is even more limited than for SCS. It specifically mentions a Cochrane systematic review that found no randomized controlled trials comparing LS to no intervention, specifically in CLTI patients deemed to have non-reconstructible peripheral artery disease.
No RCTs at all.
Yeah.
So, not strong evidence for this.
Correct. Recommendation 7.2 is also a Class 2 weak recommendation, level of evidence C low. It states that the limited data does not provide evidence that lumbar sympathectomy reduces the risk of major amputation in patients with non-reconstructible PAD. It remains unclear if it might offer some benefit for specific subgroups, perhaps purely for pain control or maybe minor ulcer healing, but not for limb salvage overall.
Okay. Intermittent pneumatic compression, IPC. We sometimes use this for lymphedema or DVT prevention. How might it work in CLTI?
Intermittent pneumatic compression involves applying sequential compression to the limb using inflatable cuffs. In CLTI, it's thought to potentially work by increasing the arteriovenous pressure gradient, essentially milking blood through the diseased vessels, and maybe stimulating the development of collateral blood vessels over time.
Is there evidence it helps?
The guideline mentions studies suggesting potential benefits, including possibly improved limb salvage rates, better wound healing, and improved quality of life with regular IPC use in patients unsuitable for revascularization. Recommendation 7.3, another Class 2 weak recommendation, level of evidence C low, suggests considering IPC for these potential benefits. Again, weak evidence, but an option.
And prostanoids. Drugs like intravenous iloprost or L-prostadil PGE1, are they effective?
Prostanoids are discussed, referencing a more recent 2018 Cochrane review that included 33 studies. That review found some evidence of efficacy for relieving ischemic rest pain and potentially helping with ulcer healing compared to placebo.
But do they save limbs?
That's the key point. Prostanoids as a class did not demonstrate a significant impact on major amputation rates or overall mortality. Recommendation 7.4 reflects this, It's a Class 2 weak recommendation, level of evidence B moderate, suggesting they may be considered for symptom relief, pain, and potentially some wound healing benefit, but they are not recommended as a primary strategy for limb salvage itself.
What about psilostazole? That's a staple medication for improving walking distance in patients with intermittent claudication. Does it help in the more severe CLTI stage?
The guideline is quite definitive and strong regarding psilostazole use specifically in the CLTI population. Recommendation 7.5 is a Class 1 strong recommendation, level of evidence B moderate, stating, do not use psilostazole to improve clinical outcomes in patients with CLTI.
A strong, do not use.
It's based on insufficient evidence from randomized controlled trials specifically conducted in CLTI patients. While it has proven benefits for claudication symptoms, pain with walking, there's no good evidence it helps with rest pain, wound healing, or preventing amputation in the context of CLTI. So it's strongly recommended against its use for these outcomes in CLTI.
That's important clarity for us specialists. Many of these patients might have been on it for prior claudication, so continue antiplatelet, statin, etc., but stop psilostazole if the primary issue is now CLTI.
That seems to be the implication of this strong recommendation against its use for CLTI outcomes.
Okay. Hyperbaric oxygen therapy, HBOT. Breathing pure oxygen in a pressurized chamber. What's the rationale and evidence here?
Hyperbaric oxygen therapy involves breathing 100% oxygen at pressures greater than normal atmospheric pressure. Proposed mechanisms in wound healing include improving tissue oxygenation in hypoxic areas, promoting angiogenesis, new blood vessel growth, and enhancing white blood cell function to fight infection.
Sounds promising. What does the evidence show?
The evidence review was, well, less than compelling. It noted a Cochrane review finding only limited evidence for improved wound healing or amputation reduction, and this came from small trials, often with a high risk of bias. Importantly, it also highlights the recent well-conducted DAMIT2-SEALS randomized trial, which specifically looked at HBOT for diabetic foot ulcers, common scenario in CLTI, and found no benefit for ulcer healing or amputation prevention compared to standard care.
No benefit in the large RCT, so not a clear winner then.
Correct. Based on this, recommendation 7.6 is another Class 2 weak recommendation, level of evidence C low. It suggests considering HBOT only for carefully selected patients who have chronic non-healing wounds despite having had optimal wound care and, if possible, revascularization. And critically, it adds the condition that this should only be considered provided there is objective evidence of tissue hypoxia, specifically citing a TCPO2 less than 10 millimeters of mercury as an example.
So it's a very niche conditional recommendation for a very specific subgroup with documented hypoxia after all other standard treatments have failed or are not possible. Not for routine use.
Exactly. A treatment of last resort in a documented hypoxic wound, perhaps.
Finally, the guideline touches on investigational approaches like biologic and regenerative medicine, things like gene therapy or cell therapy. What's the status there?
These approaches, such as therapeutic angiogenesis using growth factor genes or cell-based therapies like stem cells aimed at stimulating the growth of new blood vessels, are discussed but are clearly positioned as investigational at this stage.
Have the trials shown promise?
The guideline mentions key Phase 3 trials like Tamaris, using intramuscular gene therapy, and Mobile, using immunoselected stem cells. Unfortunately, thus far, these large trials have not demonstrated a significant benefit on primary clinical endpoints like amputation-free survival compared to placebo.
So still in the research phase, what's the recommendation for using these therapies outside of trials?
Recommendation 8.1 is very clear and strong here. It's a Class 1 strong recommendation, level of evidence B moderate, stating that the use of therapeutic angiogenesis, gene, or cell therapy should be restricted to CLTI patients who are enrolled in a registered clinical trial.
So no off-label use, only within a research protocol.
Correct. This reinforces that these are strictly research tools at present, not yet established treatments for routine clinical use in CLTI.
Okay, let's recap these non-revascularization options. For CLTI patients where revascularization isn't an option, the evidence for alternatives is generally weaker. Spinal cord stimulation and intermittent pneumatic compression might be considered in selected cases for pain relief or maybe some limb salvage potential based on limited Class 2 weak level C evidence. Prostanoids might help pain or ulcer healing, but don't impact amputation or mortality, Class 2 weak level B. Lumbar sympathectomy lacks evidence for limb salvage, Class 2 weak level C. Psilostazole is strongly not recommended for CLTI outcomes, Class 1 strong level B. Hyperbaric oxygen therapy is a weak consideration only for select patients with documented tissue hypoxia after other treatments fail, Class 2 weak level C. And biologic therapy should only be used within registered clinical trials, class 1 strong, level B.
That's an excellent summary of a complex area with often disappointing evidence. It really highlights the importance of successful revascularization whenever feasible.
It really does. But despite all efforts, best medical therapy, revascularization attempts, even these non-revascularization options, amputation remains a reality for some patients with CLTI. How does the guideline address the role and considerations around amputation?
The guideline realistically acknowledges that major lower limb amputation may unfortunately be necessary when revascularization is not technically feasible, has been unsuccessful despite attempts, or when the limb is simply unsalvageable due to extensive tissue destruction or overwhelming infection.
In what specific situations might a primary major amputation deciding upfront not to attempt salvage be the preferred or most appropriate path?
The guideline lists several scenarios where primary major amputation might be favored. These include the definitive absence of suitable target vessels for any form of revascularization, destruction of major weight-bearing portions of the foot, making functional ambulation impossible even if the limb could be saved, extensive tissue loss combined with severe life-threatening infection or sepsis that isn't responding adequately to medical treatment. And sometimes it comes down to patient preference, especially if they have very low functional status, severe pain, and understand the potentially long and arduous path of limb salvage attempts with no guarantee of success.
A difficult conversation, no doubt. When amputation is necessary, there's the crucial choice between below-knee and above-knee amputation levels, which is generally preferred and why.
The guideline explicitly compares transtibial amputation or below-knee amputation, BKA, and transfemoral amputation or above-knee amputation, AKA. It states clearly that BKA is generally preferred over AKA whenever possible.
Why the preference for BKA?
The main reason is preserving the knee joint. This significantly improves the potential for successful prosthetic fitting and, more importantly, for achieving functional ambulation for the patient. Walking with a below-knee prosthesis is far easier and more energy efficient than with an above-knee one.
Are there also differences in healing rates or even mortality between BKA and AKA?
Yes, the guideline notes several differences. Healing rates for the amputation stump are generally reported to be higher after BKA than AKA. Correspondingly, success with prosthetic fitting and achieving independent ambulation is better after BKA compared to AKA.
And mortality? That's often high after major amputation in this population.
Unfortunately, yes. Major lower limb amputation in frail CLTI patients is associated with high perioperative and long-term mortality rates. The guideline specifically states that mortality rates following major lower limb amputation are often higher for above-knee amputation compared to below-knee amputation.
So preserving the knee joint with a BKA offers better functional outcomes, potentially better healing, and potentially better survival. A trifecta of benefits if achievable.
Precisely. Every effort should be made to achieve a BKA level if viable.
Is there anything that can be done surgically, besides distal revascularization, to help facilitate a lower-level amputation? Maybe improve inflow just enough to heal a BKA?
The guideline mentions one possibility: profundoplasty. This is a surgical procedure specifically to clean out or bypass disease in the deep femoral artery, profunda femoris, in the thigh, by improving blood flow into the thigh muscles served by the profunda. This improved inflow can sometimes allow for a lower amputation level. Specifically, it might make a below-knee amputation possible and likely to heal when it might otherwise have failed, thus preserving the knee joint.
So assessing the profunda is important when planning an amputation level. And is there a reliable way to predict if a chosen amputation site is likely to heal?
The guideline briefly notes that predictive methods exist to help guide level selection. Using measurements like transcutaneous oximetry, TCPO2, or skin perfusion pressure, SPP, at the potential amputation level can help assess the viability of the tissue there and predict the likelihood of successful stump healing. A certain minimum perfusion pressure is generally needed.
Okay, so to summarize the amputation discussion, it's a necessary reality when limb salvage fails or isn't feasible and may be preferred upfront in certain severe situations. Below-knee amputation is strongly preferred over above-knee due to better functional outcomes, better healing, and potentially lower mortality. Profundoplasty might sometimes help achieve a BKA level, and tools like TCPO2 or SBP can help predict healing at the chosen level.
A good summary of the key considerations when facing that difficult decision.
Now, shifting gears back to patients who have had successful revascularization. The job isn't done then, right? What are the crucial aspects of long-term care and surveillance needed to maintain those results and prevent recurrence?
Absolutely. The job is definitely not done after the revascularization procedure. The goals of long-term management and surveillance after revascularization are primarily to improve the durability or patency of the repaired or bypassed vessels, and consequently, to improve long-term limb salvage rates. We want the fix to last.
How should this surveillance be conducted? Is just asking the patient about symptoms and checking pulses in clinic sufficient?
The guideline is quite clear that clinical follow-up alone is often insufficient, particularly after infrainguinal bypass surgery. Vascular lesions, like restenosis at an endovascular site or stenosis within a vein graft, can develop and become hemodynamically significant, threatening the limb again before the patient actually experiences recurrent symptoms like pain or new tissue breakdown.
So we need objective testing. What's the most valuable tool for surveillance in this setting?
Duplex ultrasound, DUS, is highlighted as providing invaluable information. It's non-invasive and gives both anatomic detail, visualizing the vesicular graft, and physiologic information, measuring blood flow velocities. It allows us to track changes over time by measuring parameters like peak systolic velocity, PSV, within the treated segment, and the PSV ratio compared to a normal segment upstream. These measurements help detect developing stenosis or impending occlusions before they become critical.
What are the specific recommendations for using duplex ultrasound surveillance? When and for whom?
Recommendation 10.0 is a Class 1 strong recommendation, level of evidence B moderate. It recommends duplex ultrasound surveillance at regular intervals after infrainguinal vein bypass.
Oh, regular.
The guideline suggests using surveillance intervals similar to those established for primary vein grafts in numerous prior studies. This typically involves more frequent checks early on, for example at 1, 3, 6, 12 months, and then spacing them out, for example annually if things remain stable. The goal is to catch stenoses while they are treatable before the graft thrombosis.
What if a vein graft has already needed a revision, maybe an angioplasty or a patch repair? Does surveillance continue?
Yes, definitely. Recommendation 10.11, also a Class 1 strong recommendation. Level of evidence B moderate, advises maintaining long-term surveillance after either a surgical or catheter-based revision of a vein graft. This is crucial because revised grafts are known to be at particularly high risk for developing recurrent lesions. Surveillance is arguably even more important then.
And what about surveillance after bypass using prosthetic grafts, like PTFE?
The evidence for formal duplex ultrasound surveillance programs specifically for prosthetic grafts is noted as less conclusive compared to vein grafts. Prosthetic grafts tend to fail more catastrophically by thrombosis rather than developing a treatable stenosis. However, DUS can still be used to assess prosthetic grafts if there is a clinical suspicion of impending failure or stenosis based on symptoms or pulse changes. Routine scheduled surveillance is less strongly advocated.
Okay. What about surveillance after endovascular interventions, angioplasties, stenting? Is routine imaging recommended there?
For endovascular interventions, the guideline takes a slightly different, less intensive approach to surveillance. Recommendation 10.12 is a Class 2 weak recommendation, level of evidence C low. It suggests considering arterial imaging, which could be duplex ultrasound or maybe even repeat angiography, after endovascular intervention, specifically if the patient develops recurrent symptoms. Routine imaging surveillance in asymptomatic patients after endo is not recommended in the same strong manner as it is for vein bypasses.
So more symptom-driven surveillance after endo, more routine programmatic surveillance after vein bypass.
Generally, that seems to be the distinction based on the evidence and recommendations.
Let's circle back to antiplatelet therapy, but now in the context of secondary prevention after an intervention has been performed. We know everyone with CLTI needs at least one agent. What about DAPT post-procedure?
Yes, continuing optimal medical therapy is absolutely essential for long-term success after revascularization. The guideline discusses considering dual antiplatelet therapy, DAPT, typically aspirin plus clopidogrel, for a limited period after certain types of interventions, aiming to improve patency.
Which interventions warrant consideration for DAPT, and for how long?
Recommendation 10.3 is a Class 2 weak recommendation, level of evidence B moderate. It suggests considering DAPT for patients who have undergone infrainguinal prosthetic bypass for CLTI. The suggested duration here is potentially longer, maybe 6 to 24 months, with the goal of improving graft patency as prosthetic grafts are prone to thrombosis.
Okay, DIPT consideration after prosthetic bypass. What about after endovascular procedures?
Recommendation 10.4, also a Class 2 weak recommendation but with level of evidence C low, even weaker evidence, suggests considering DIPT after infrainguinal endovascular interventions like angioplasty or stenting. The suggested duration here is typically shorter, maybe 1 to 6 months.
So DAPT is a consideration after both prosthetic bypass longer duration maybe, and endovascular interventions, shorter duration maybe. But importantly, both are weaker recommendations. Class 2, weak. Why weak?
Because, as the guideline explicitly points out, you have to carefully balance the potential benefit in improving patency, which is not definitively proven in all scenarios, against the very real increased risk of bleeding associated with DAPT, especially in these often elderly, frail patients who might be on other medications too. It's a risk-benefit calculation for each patient.
Makes sense. And what about psilostazole post-intervention? Maybe it helps keep things open then.
No. The guideline reiterates its strong stance on psilostazole in the CLTI population, even after intervention. Recommendation 10.7 is a Class 1 strong recommendation, level of evidence B, explicitly stating against using psilostazole to improve outcomes like patency or limb salvage in CLTI patients, even after they have undergone a revascularization procedure. Still not recommended for CLTI.
Okay, very clear. Beyond specific treatments and surveillance strategies, the guideline also looks at the bigger picture of how we generate evidence in this field. It discusses the challenges of clinical research in chronic limb-threatening ischemia. What are some of the key difficulties highlighted in designing and conducting good CLTI trials?
CLTI trials are notoriously challenging to conduct well. The guideline highlights several reasons. The patients themselves are very heterogeneous, varying degrees of ischemia, wound complexity, infection, comorbidities. They are often elderly and frail.
Right.
They are also prone to experiencing multiple different types of clinical events during follow-up, needing repeat interventions, developing new wounds, having minor or major amputations, suffering cardiovascular events like heart attacks or strokes, and unfortunately, high mortality rates. This makes defining and analyzing primary endpoints very complicated.
What else makes trials difficult?
It's often difficult, if not impossible, to blind studies, especially when comparing a very obvious open surgery to a less invasive endovascular procedure. Patients and assessors usually know what was done. And even defining clinically relevant, objective endpoints can be complex. Is patency alone enough? What about wound healing? Function.
To help address some of these challenges, particularly when evaluating new devices or techniques where a full RCT might be difficult initially, the guideline introduces the concept of objective performance goals. Can you explain those?
Yes, objective performance goals, or OPGs, were developed by the Society for Vascular Surgery Critical Limb Ischemia Working Group. They are introduced in the guideline as potentially useful benchmarks. Recommendation 11.3, presented as a good research statement, suggests using OPGs to evaluate novel endovascular techniques.
How do they work?
Essentially, OPGs provide pre-specified outcome targets, like minimum acceptable rates for limb salvage, freedom from reintervention, etc., based on historical data from similar patient populations treated with established therapies. A new technique or device might be compared against these preset goals in a single-arm study as an initial assessment of whether it warrants further investigation in a larger, possibly comparative trial. They offer a performance threshold.
That sounds useful. The guideline also discussed the limitations of using endpoints like amputation-free survival, AFS, as the sole measure of success in trials. What's the issue there?
The guideline argues strongly for the need for relevant and comprehensive endpoints, beyond just AFS. While amputation-free survival is widely used and important, it has significant limitations as a sole primary endpoint.
Such
Well, first, it doesn't capture the level of amputation. A transtibial below-knee amputation has vastly different functional consequences than a transfemoral above-knee one, but both count the same in AFS. Second, the timing of amputation can sometimes involve clinical judgment or patient choice, which is hard to standardize or blind in a trial setting. And importantly, AFS alone tells you nothing about other crucial outcomes like relief of pain, successful wound healing, the patient's functional status, their quality of life, or the need for repeated costly reinterventions to maintain limb salvage.
So it doesn't fully capture the patient's experience or the true burden of the disease and its treatment. What does the guideline recommend including in trials in addition to objective events like amputation or death?
Recommendation 11.7, another good research statement, strongly emphasizes the critical importance of incorporating patient-reported outcome measures, or PROMs, and health-related quality of life, or HRQL, assessments into CLTI trials. These should be used alongside the traditional objective clinical events like amputation, patency, mortality, to get a more complete and meaningful picture of the intervention's overall benefit from the patient's perspective. What truly matters to the patient being pain-free, healing their wound, being able to walk, maintaining independence needs to be captured systematically.
Are specific tools for measuring PROMs and HRQA mentioned?
Yes, the guideline lists several widely used and validated instruments. These include generic health status measures like the 12-item short-form health survey, SF-12, and the Eurocall 5-dimension, Eurocall 5D, as well as disease-specific tools like the Vascular Quality of Life Questionnaire, VascuQual, which focuses more on PAD-related issues.
What about the length of follow-up required in CLTI trials? How long do we need to watch these patients?
The guideline stresses the need for adequate follow-up periods. Because CLTI is a chronic condition and interventions can have late failures or complications, short follow-up might miss important events. They recommend follow-up durations greater than 1 year and ideally greater than 2 years to capture the natural history of the disease, the durability of interventions, and the potential for multiple events over time.
Transparency in research is also highlighted as crucial for trustworthy evidence.
Absolutely. Recommendation 11.11, a good research statement, emphasizes the importance of transparency by stating that all CLTI trial protocols and their full statistical analysis plans should be published in peer-reviewed journals, preferably before the trial starts or completes enrollment.
Why is that important?
This allows for independent scrutiny of the plan methods and endpoints. It also helps prevent selective reporting or publication bias, where perhaps only positive trials or positive results within a trial get published, giving a skewed view of the evidence. Full transparency is key.
And beyond formal randomized trials, is there still a role for other types of data collection, like registries?
Yes. Recommendation 11.12, another good research statement, highlights the continued importance of ongoing surveillance through well-designed, large prospective observational studies and national or regional quality registries, even after pivotal randomized controlled trials are completed.
What value do registries add?
They can provide valuable, real-world data on how therapies are being used and how patients are faring outside the strict confines of a clinical trial. They can track long-term outcomes in broader, more diverse populations and help identify trends or rare complications that might be missed in trials. They complement RCTs.
Finally, wrapping up the research section, what are some of the key research priorities a guideline writing group identified as needing the most focus going forward? Where are the biggest knowledge gaps?
The guideline lists several important research priorities in Section 11. These include things like definitively clarifying the clinical value and specific indications for angiosome-based versus indirect revascularization, better defining the relative value of endovascular versus open surgical therapy in different specific patient subgroups based on WIFI, GLASS patient risk, further validating the GLASS and WIFI systems themselves for predicting outcomes across diverse populations, developing reliable, maybe even real-time tools for assessing foot perfusion in the clinic or cath lab setting, and importantly, developing consensus definitions for reporting post-intervention patency to standardize how we report results across studies.
So lots of work still to do.
Absolutely. These are all areas where the current evidence is still insufficient to provide definitive Class 1 recommendations, leaving room for clinical uncertainty.
Okay, so recapping the long-term care and evidence generation aspects. Post-revascularization, ongoing surveillance is crucial, particularly routine duplex ultrasound for vein grafts, while maybe more symptom-driven for endo. Secondary prevention with aggressive medical therapy must continue, with only weak evidence supporting consideration of diabetes for limited periods after certain interventions, and strong evidence against using psilostazole for CLTI outcomes. Generating better evidence is hampered by patient heterogeneity and complexity, but using tools like objective performance goals, incorporating patient-reported outcomes and quality of life measures alongside traditional endpoints, ensuring adequate follow-up, demanding transparency, and leveraging registries are all key strategies. And major research priorities remain around optimizing revascularization strategies, validating risk tools, and improving assessment and reporting.
That's a great wrap-up of the post-procedural and research landscape described in the guidelines.
That provides a clear picture of current best practice and where the field is heading. Finally, let's consider how these comprehensive guidelines are actually implemented or ideally should be implemented across different healthcare systems globally. The guideline introduces the concept of an amputation prevention team. What's that about?
Yes, the guidelines strongly advocate for an organized, team-based, multidisciplinary approach to caring for these complex CLTI patients. They recognize that optimal care often requires input from various specialties. They propose different models for delivering this care based on available resources, outlining basic, intermediate, and the aspirational center of excellence models.
Can you briefly describe these different models?
Sure, a basic model might be quite limited, perhaps involving just a general practitioner and a specialist nurse working together in an outpatient setting, focusing on risk factors and basic wound care. An intermediate model might be found in a district or community hospital, perhaps with a multidisciplinary clinic focusing specifically on wound care and limb salvage, maybe akin to a dedicated diabetic foot clinic, with access to some specialists but perhaps not all interventions.
And the Center of Excellence model is the most comprehensive, top-tier approach.
Correct. The Center of Excellence model is typically envisioned based in a tertiary care hospital or major academic center. It's characterized by having a dedicated, standing, multidisciplinary team of specialists who work collaboratively. They follow established evidence-based clinical pathways and protocols for diagnosis, treatment, and follow-up. They actively monitor their outcomes, focus on continuous quality improvement, and often serve as an educational resource for the region. Crucially, these centers have access to the full spectrum of advanced diagnostics and both endovascular and open surgical interventional capabilities.
Who is typically on this ideal multidisciplinary team in a Center of Excellence, according to the guidelines? It sounds like it would need quite a few players.
It's quite a comprehensive roster listed, really reflecting the multifaceted nature of CLTI. The suggested core team ideally includes specialists in vascular surgery, vascular medicine, interventional cardiology, and a NOR interventional radiology, depending on local practice patterns for peripheral interventions, podiatry, dedicated wound care providers, often specialist nurses, endocrinology for diabetes management, infectious disease specialists for complex infections, orthopedic or plastic surgeons for complex reconstructions or amputations, rehabilitation medicine specialists, physiatrists, physical therapists, and orthotists, prosthetists.
Wow.
And notably, they also suggest including methodologists on the team, likely to support robust data collection, outcomes analysis, and quality improvement initiatives.
That's a formidable team requiring significant resources and coordination. And a key feature is that they emphasize protocol-driven care and quality assurance.
Absolutely. A hallmark of the Center of Excellence model is adherence to written evidence-based protocols or clinical pathways for managing CLTI patients consistently. They also stress the importance of setting explicit quality assurance goals and systematically monitoring key process and outcome metrics.
What kind of outcomes should these centers ideally be tracking to ensure quality?
Examples given include tracking things like wound healing rates and time to healing, revascularization success rates, both technical and clinical, rates of repeat procedures or reinterventions, major amputation rates, hopefully low, and patient-centered outcomes like functional status changes and quality of life improvements. The guideline does acknowledge, however, that collecting these detailed metrics consistently can be challenging, even with modern electronic health record systems. It requires dedicated effort.
Okay. The guideline also includes a dedicated chapter offering a global perspective, drawing insights from a survey of specialists around the world. What did that reveal about the variability of CLTI care internationally?
The Global Perspective section, which was based on survey responses from vascular specialists in various countries across different income levels, really highlighted significant variations in how CLTI presents, how it's diagnosed, and how it's managed across different healthcare environments globally. It underscores the challenge of applying a single resource-intensive guideline uniformly everywhere. Reality differs greatly.
What are some of the specific challenges faced in low and middle income countries, LMICs, that the survey brought to light?
The challenges reported from LMICs are substantial. Patients often come from disadvantaged socioeconomic backgrounds, presenting later with more advanced disease. There's often severely limited access to advanced diagnostics and imaging technologies that we might take for granted, things like readily available CTA, MRA, duplex ultrasound for detailed mapping, or formal vein mapping before surgery.
What about treatment resources?
The availability of specific endovascular devices, like specialized wires, balloons, stents, atherectomy devices, or even appropriate prosthetic grafts for bypass can also be quite limited or prohibitively expensive. Furthermore, significant challenges exist with consistent access to appropriate antibiotics for treating infections and obtaining adequate wound care supplies.
And the financial burden on patients themselves in some regions. So does the guideline touch on that?
Yes, the survey responses, particularly citing the example of India, highlighted the significant burden of high out-of-pocket healthcare expenses in some LMICs. This frequently forces patients and their families to rely on household income, deplete savings, or take out loans to pay for hospitalization and complex treatments like revascularization or amputation. This can, tragically, lead to impoverishment even if the limb is saved.
That's a sobering reality.
Yeah.
Is there also variation reported in the use of non-revascularization treatments globally, perhaps influenced by these resource limitations?
Yes, the survey suggested some variation in the use of these alternative approaches. While evidence-based revascularization is universally recognized as the goal, the responses indicated that some non-revascularization treatments, such as lumbar sympathectomy, might still be employed more frequently in certain regions, despite the limited evidence supporting their effectiveness in reducing major amputation risk.
Come on back that way.
The guideline writers speculate this might reflect a pragmatic, perhaps desperate, desire by clinicians to provide some form of treatment or hope to patients when more definitive, evidence-based revascularization options aren't suitable, available, or affordable. Even if the supporting data for these alternatives is weak, doing something might be perceived as better than doing nothing in a dire situation.
A reflection of the resource constraints and difficult choices faced globally.
Exactly. It highlights the gap between ideal guidelines and real-world practice in many settings.
So to sum up the implementation and global perspective, the guidelines strongly advocate for organized, multidisciplinary, team-based care with the Center of Excellence model as the ideal structure. However, actually delivering this high standard of care faces significant hurdles globally, particularly in low and middle-income countries. These hurdles include socioeconomic factors, limited access to diagnostics and therapies, financial burdens on patients, and resulting variations in practice patterns, which can sometimes lead to the continued use of less evidence-based treatments out of clinical necessity or local tradition.
A very accurate picture of the implementation challenges outlined.
This has been a really deep and truly comprehensive dive into the global vascular guidelines on chronic limb-threatening ischemia. We've covered so much ground. The evolution of terminology from CLI to CLTI to better reflect the patient population, the absolute necessity of objective hemodynamic assessment tailored to the patient, especially pushing for toe pressure and TCPO2, the power of using standardized systems like WIFI and GLASS for staging limb threat and planning interventions, the foundational role of aggressive, multifaceted medical therapy targeting multiple risk factors, the nuanced evidence-based or evidence-limited decision-making process for revascularization, using the PLAN framework and understanding the pros and cons of endo versus open vein bypass, acknowledging the limited role of non-revascularization options for highly selected patients where intervention isn't possible, the critical importance of structured team-based care models like centers of excellence, and finally, confronting the significant global disparities in resources and access that hinder implementation of this high standard of care everywhere.
It's a landmark document, really attempting to synthesize current knowledge while also being commendably transparent about where the gaps are and where future research and health system efforts must be focused. It's a roadmap, as you said earlier.
It truly is. And that leaves us, and you, the specialist clinician listening today, with some important, perhaps challenging questions to ponder. Considering the many research priorities identified in these very guidelines, things like clarifying the best revascularization strategy for complex tibial anatomy, improving our real-time perfusion assessment tools, and developing better, more patient-centric trial endpoints, how can we, as a global community of vascular specialists, actively contribute to generating the high-quality evidence needed to truly move the needle and eliminate preventable amputations in chronic limb-threatening ischemia?
A critical question for all of us involved in research and practice improvement.
Or perhaps just as critically, looking at it from the implementation side. Given the striking disparities in care highlighted across different healthcare environments, how do we work collectively through education, advocacy, innovation, policy changes to ensure that the principles and recommendations within these comprehensive guidelines translate into meaningful improvements in outcomes for all patients suffering from CLTI, regardless of their socioeconomic status or where they happen to live? These are the challenges that lie ahead beyond the pages of the guideline itself.
Absolutely. Translating knowledge into equitable practice globally is the ultimate goal and the ultimate challenge. Important questions to ponder indeed.
Thanks for joining us for this very detailed deep dive.